Hey guys, it's Mrs. Melodigan. We're going to finish up chapter 4 today. The information that we're going to go over today is in an additional PowerPoint that you'll find on the website. The information doesn't necessarily come straight from chapter 4, but we're talking about legal and ethical issues. And some of the material that I'm required to teach you isn't included in your book, so you will find it in that additional PowerPoint. You are still responsible for the material on your test, so make sure you take note of things here today. There are 4 objectives for the day that we have to identify different forms of advanced directives and be able to tell the difference between them. You need to know different options people have when they're writing out their advanced directives. You need to identify purpose of an informed consent and legal issues that there are when we have to witness an informed consent. And last but not least, you need to identify legal and ethical issues around the use of restraints. So you can follow along in your on the PowerPoint if you'd like. We're going to go ahead and get started. So first of all, what is an advanced directive? It's a legal document, which means, of course, that we have to, by law, make sure that we follow it. It is a legal form that somebody would fill out while, of course, they are alive, they are competent, and they're able to make their own decisions. So what does it mean to be competent? In this case, what it means is that you can't have any type of health issue, mental health, physical health, maybe dementia, things like that, that would make you unable to make decisions in your, quote, right mind. It could be that you would not be able to fill it out if you're under the influence of some kind of substance. Maybe we've given you pain medicine, or you're under the influence of drugs or alcohol. When you're under the influences of those substances, you're not considered to be competent, so you wouldn't be able to fill it out. So while you're alive and you're competent, you fill out this form and you make decisions for yourself for when you are no longer able to do so by yourself. There was an act that went into law in 1990 called the Patient Self-Determination Act. And what this law did is required any type of facility that got reimbursement from Medicare to ask all patients, whether they received Medicare or not, if they had an advanced directive. If they had an advanced directive, we are then required by law to follow them and to keep one on hand and refer to it as needed. And it also required us that if people didn't know what an advanced directive was, that we educate them about them. There's different kinds of categories of advanced directives. The first is a living will. And what this does is it is a legal document that talks about you not wanting to postpone your death by any kind of artificial means. Things like a ventilator, feeding tubes. And you ahead of time sit down, you fill out this form, and you say what you do and you don't want, should you not be able to make decisions for yourself. Now, you can also choose to have what's called a durable power of attorney for healthcare purposes. And what this does is it makes a spouse, a family member, a friend, someone in charge of making your decisions for you if you become unable to for some reason. So the best way I can explain this is using myself. So let's say that I was in some kind of accident and I was unable to make decisions for myself. If I did not have one of these, the decision making would automatically go to my next of kin. Because I'm married, it would go to my husband. But if I wasn't married, it would go to maybe my mother or my children. It all depends on who the next closest relative is. If, though, I wanted to put somebody else in charge of that decision-making process, ahead of time, I could fill one of these out and put someone else in charge. So maybe I decided that since my mom is a nurse, that I wanted her to make my decisions. And so I would discuss with her ahead of time, make sure she knew, and then that person would then be responsible for making those types of decisions. It would override that next of kin so that if I had one of these, whoever I put in charge is going to be the one that has to make all of those decisions. Now, when you're filling these out, you have essentially some different options that you can choose. The first one is supportive care. So these are things that don't prolong somebody's life, but supports it, kind of like its name implies. So it makes people a little more comfortable. Things like providing them with oxygen and nutrition, pain medication, grooming, hygiene, getting baths, getting your hair combed, things that are just going to make you more comfortable, and not have to suffer. Another option is life-sustaining treatments. This would be for people who want everything. They want CPR. They want to be on a ventilator. They want to be kept alive as long as possible. They want everything possible to be done that can be done in order to keep living. And last but not least, you kind of have you have the option of what's called a DNR, which stands for Do Not Resuscitate. And when somebody chooses to be a DNR, what that means is they do not want CPR. They don't want any kind of life-sustaining treatments done for them. So if somebody is a DNR and I as a nurse go in and find them not breathing, I cannot start CPR, even if I think that person should have chosen to have that option. It's their choice, and if they are a DNR, remember, it's a legal document and we have to follow it. So when someone is a DNR, we can't give CPR, we can't do those things to try to bring them back to life. All right, so we're going to kind of switch gears a little bit here. I talked about informed consent. So I kind of hinted at this earlier in a chapter when we were talking about the different legal violations that can occur and how we can be charged with battery if we do a procedure without informed consent. So this informed consent, what it is done before any type of procedure that we do in healthcare. And the doctor's responsible for going in and explaining all of the benefits, all of the risks, all the complications, all the alternatives, tell them who's going to be doing the procedure. Any kind of information that person needs, they have to give it to them. And then as a healthcare worker, we would then witness that conversation. Now, when we witness, we're not saying that the person understands. We're witnessing that the conversation took place and that the patient actually signed the form. So, for instance, an informed consent form, because I am a labor and delivery nurse, the one I'm used to signing is a C-section consent. So they would talk with the patient ahead of time about all the risks. Things like maybe an injury to the bladder or the ureter or hemorrhage. They would talk about the benefits. Of course, the benefit would be a healthy baby, being able to get the baby out quicker, things like that. Complications that could come from it. It's major abdominal surgery. It has complications associated with it. So they would talk about those. Alternatives is vaginal delivery, an alternative to the C-section for whatever reason, and talk about who's going to be doing the surgery. Now, when consents are filled out, there are a couple rules. First of all, use black ink. Okay? No red ink, no blue ink, no purple or green or any of those other pretty little colors. In healthcare, we use black. And while we're talking about using ink pens, let's talk about what kind of ink pens that we should use. Those gel pens that smear when you get them wet? This is a legal document, so in the off chance that something would be spilt on it, we don't want it to run off. We want to be able to go back and refer to it and see the patient's signature. So we need to use some kind of ballpoint pen that's not going to smear. When we're filling out these forms, we cannot use any types of abbreviations. In healthcare, as you're going to learn, we use a lot of abbreviations. It makes things quicker for us. It makes things easier for us. But when we're filling out these consent forms, that's not an option. And we have to spell things correctly, and that's very important in healthcare. When we're charting and we're documenting and we're using forms that have become legal, we have to spell correctly. So the consent forms are no different. Now, there are instances where we need consent from somebody who may not be there. So let's say, again, using me as an example, let's say I went away and I left my children with my parents, and they fell off the sliding board, or they fell off the swing, they got hurt somehow. If I don't have an advance directive filled out for my children that my parents can make the decisions for them, I am the one that has to make those decisions, so care would not be able to be given until I gave consent. So there's something called a telephone consent, and in order to do that, it requires two people listening in on the conversation between myself and the doctor, and both witnesses would then have to sign. So, if, say, they broke their arm and they needed to have surgery and I was in a different country on vacation or something, they would have to call me, wait until they could get a hold of me. Two people would listen in, and after the conversation, they would sign it, and then they could continue on with their care. Now, one thing that varies from state to state is laws surrounding minors, meaning people under the age of 18. For the most part, people under the age of 18 are not going to be able to sign legal documents. They're not going to be able to sign informed consents. They have to have a parent. Now, there's some exceptions to that in some states. We're not going to get into all of that, but just know that there are some exceptions to that. There are, however, depending on the state that you live in, something called emancipated minors. So this is a self-sustaining minor, meaning that they're living on their own. It could be that the person has had a baby. It could mean that they don't have parents and they support themselves. This is they have to have some kind of paperwork supporting that document. They can't just say, well, I am a self-supporting minor. It has to be documented. It is a legal thing. So you kind of have to be familiar with whatever state that you live in and what kind of rules there are. For the most part, you guys will probably function in PA, maybe Maryland. In PA, if a teenager has had a child, they are an emancipated minor. They can sign consent for their children, things like that. Now, if you lived in a different state, the rules and the laws may be completely different. That's part of knowing your job and knowing what the rules are where you live. And that's it with informed consents, but we're going to move on then to the last topic of the day, which is restraints. And so there's two kinds of restraints. There's physical and chemical restraints. Any kind of physical thing that we put on a person's body to restrain them, keep them somewhere, keep them from moving, is considered to be a physical restraint. And there are many different types of physical restraints. There's wrist restraints, ankle restraints, vests, waist restraints or lap belts. Even chairs and tightly tucked sheets can be considered a physical restraint. Side rails can be considered a restraint. And many facilities are moving to a restraint-free policy, saying that we're not going to restrain our patients in any way. So you kind of have to be very familiar with what your facility's policies are with using side rails, with using sheets and certain kinds of chairs that would kind of keep somebody in their chair. The other kind of restraint is a chemical restraint, and that is any kind of medication that would alter a person's mood or behavior. Now, in your textbook, there is a whole section on using restraints and some rules I encourage you to go review that. I believe that is on page 166 to 175. Should be in chapter 10. If you have any questions, I'll double check that at those pages for you and let you know. But when we use restraints, they should never be done as a punishment. When we use a restraint, they need to be done for supporting someone's posture, for protecting the person from harming themselves, things like that, or maybe even from harming us. Now, when we use restraints, we have to have a doctor's order, and the doctor has to write that order every 24 hours. The doctor has to come in and see that patient every 24 hours in order to make sure that their condition hasn't changed in some way. And I just double checked the page numbers. It does start there on page 166 for you to review. Now, when we do have to use restraints, we need to use the least restrictive. Can we get away with just using one, or do we need both hands restrained? They have to be done or attached to some part of the bed or chair that's not movable. Like, I don't want to attach a restraint to the side rail, and then if I move the side rail, the patient would end up getting injured. That's not okay. So they have to be attached to a non-movable part. They have to be able to be released in an emergency. We have what's called a quick release knot, and I'll show you what that is in the lab, but you have to be able, with one tug, be able to release it in case of an emergency situation. Maybe you walk in and you find that the person has wiggled themselves down into some kind of odd position and they're choking. You need to be able to release that with one little tug and be gone. Now, when somebody is in restraints, you do need to check them more frequently. You need to check them like every 10 minutes. And there are some other rules when using restraints. Things like that every 2 hours that you take them out of the restraints for every 10 minutes. Things like that. So that you don't impede circulation and you don't cause any kind of complications that are associated with restraints. And there's also some of those rules in that section that I told you about. I highly suggest that you look over some of those as well. Another thing with restraints is that we need to try other things. We can't just automatically go to restraint. Some of the things that different facilities try is maybe putting a nurse aide, like one-to-one with the person, putting bed alarms on the person, which basically means if they get out of bed, the alarm goes off. And they have busy boxes in some places that have different activities that keep them sidetracked and things like that. And you would be surprised how busy some residents can be, especially residents. Little old ladies are stronger than strong sometimes, and keeping them in bed. They'll crawl out of places, they'll crawl in between bed rails and things. So you really have to be careful with using restraints. People who are in restraints are actually 8 times more likely to die than people who are not. There are complications with using restraints, things like strangulation and bruises and nerve damage and abrasions and impaired blood flow, things like that. Pneumonia from laying in bed, and pressure ulcers or bed sores, also called decubitus ulcers. Blood clots. All of these things are associated with using restraints. So we don't want to use them unless we absolutely have to. Now, when it comes to restraints, we'll also be talking about this in Chapter 10 when we go over safety. So we'll be reviewing this information again because it is important. So you do need to be familiar with it. But if you have any questions about any of this, informed consent, advanced directives, restraint use, go ahead and email me and I'll get back to you. Otherwise, this is the end of Chapter 4. We will be reviewing tomorrow. There is a link to the review sheet if you want to look ahead and see what kind of questions are on the review sheet. And we'll see you tomorrow. See ya.